Next speaker is Dr. Dushyant Khedikar.
Good morning, all. So, my topic of presentation today is recurrent benign paroxysmal positional vertigo. My job has been made very simple by today's oration, but great oration by Dr. Srinivas, sir. Thank you very much, sir. So, there are many instances when we come across not a very classical picture of a positional vertigo. The patient may walk into a clinic with a vague heaviness in the head, sometimes the neck stiffness, and sometimes a swaying while walking, and all these things. And we keep on wondering, but if we ask the patients in details, we get a history that he has, sometime in the past, has sustained an episode of benign paroxysmal positional vertigo. Okay? But the present symptoms are not very suggestive. So why this is there? Because BPPV primarily is an utricular disease. Okay? So what happens inside the utricle? We'll just go to the slides. I will just change the sequence of my slides. So this is the picture of utricles in the macula. Okay? So what you can see here, where is the cursor? Okay. Is the cursor seen? Okay, fine. So here we can see the utricles. Okay, very well, utricles. This is the ice fractured. Okay, fine. So these are the utricles. These are the otoconia, and the otoconias are embedded in a matrix of a gel which is formed by glycoproteins. So the macula is a combination of calcium carbonate crystals which are rhomboid, hexagonal, and they are gelled together by glycoproteins. Primarily, so these otoconias, if we have an even detailed view of these otoconias, what we can notice is that they have got small pores on their surfaces. Now, why this is so important? Because these pores, they are important for the calcium hemostasis in the endolymph, as well as they are important for maintaining the calcium carbonate covering over the otoconias. Here we see a single otoconium, a cross-sectional view, where the core is, it is not completely a calcium carbonate crystal as such. The core is primarily a glycoprotein. There are three proteins mainly, the otoconin 90, which is almost 90% of the glycoprotein, the otopetrin, and osteospongin. So osteospongin is primarily responsible for maintaining the thick calcium deposits around the otoconium. So it is the calcium in the serum which actually perfuses through the membrane and get deposited along the otoconium. So any loss in the protein mechanisms can hamper the calcium or calcification of the otoconium. Again, this is the same picture we can see here. They are typically hexagonals. Fine. Now, these were two important cases of posterior canal occlusion in the patients who had refractory benign paroxysmal positional vertigo. So they underwent the posterior canal occlusion surgeries, and what was seen is that when the posterior canal was opened, there was a plug of otoconium lying in the semicircular canal. Now this plug was further then studied, and what was found is that these otoconiums, some part of they are free, while few of them, they are very much attached to the gel matrix. Now what happens as such is that whenever now we can see that in detailed view, the gel matrix and the otoconium. So when the macula is unhealthy, either because of the calcium metabolism or because of anything going wrong with the circulation or the protein metabolism, this otoconium plug can get dislodged from the macula, and then this otoconium plug enters the semicircular canal, causing the symptoms of BPPV. So it is important that If the otoconium are embedded or they get adherent to the endolymph, semicircular membrane, the patient may have a refractory benign paroxysmal positional vertigo. At the same time, if this plug do not get absorbed and it keeps on coming in the canal again and again, it can cause the recurrent symptoms of BPPV. So accordingly, I will go back now. Now, yeah, fine. So accordingly, for the understanding of BPPV, we can divide BPPV into two types, a primary type and secondary type. Primary we largely know as idiopathic one, and the secondary which is happening because of certain disorders affecting the labyrinth. So now this was a mega review. Almost 40 odd studies were included in this review, and more than 13,000 patients were examined in this review. So what was seen that the most common cause of recurrences were hyperlipidemias, hypertension, and cardiovascular risk factors. Second to it was cervical osteoarthritis, and then came the advancing age, female gender, Meniere's disease, and other causes. But this data, vitamin D, now in our clinic practice, what we see is that in our own setup, we have recurrences of around 20%, and most of these patients, they are deficient in vitamin D, which is acrossly common. Of the 20% patients, less than half of them are above 60 years of age, and majority of them are below 60 years of age. That means there has to be something more other than these factors, because most of the patients suffering from a recurrent kind of a disease, they have a sedentary lifestyle, vitamin D deficiencies, migraine. They are the leading causes of having a recurrent diseases. Okay. So this paper, it focused on why the disease can be recurrent, that I have already explained to you. That is the ratio between the free otoconia and the gel matrix that breaks away from the utricular otolith organ. Could it be that in those are clumpier and heavier ratio of matrix? Where the matrix is more, it will be difficult to get repositioned, and there will be chances of recurrences or a refractory cases more. So what can we do to prevent the recurrences? First thing is, recurrences cannot be completely reduced. It can be completely eliminated, it can be reduced. For that, a proper diagnosis is very, very important. Like we have seen that there are the cases like utricular otolith migrations, which can cause swaying sensations and all these things, where you have to be really careful and diagnose the conditions. And there had to be some strict protocol when to declare the patient to be treated. You should have the evidences. What we generally follow is that at least for 3 successive times, if we see that there is the video histogram is not showing any vertigo and the patient is completely symptom-free, then only we declare the patient to be treated. If we follow these things, then the recurrences rate should definitely drop down. Appropriate canal repositioning maneuver should be instituted. The time of onset of the disease and diagnosis and repositioning maneuver is very important. The older the disease, the chances of having a refractory disease are more, as well as the recurrences are also more. Complete recovery shall be defined, that we have already seen. Associated risk factors, very important. Vitamin D deficiencies, calcium metabolisms, Meniere's disease, lifestyle modifications, ambulations particularly is very, very important, should be given. Patient counseling and education, that a single maneuver is never a complete curative maneuver. It can recur back. So the patient has to be aware about that thing. And for the refractory cases, vestibular rehabilitation is really, really helpful. Thank you. Yeah.
Thank you, Dr. Prashant. Thank you, Dr. Dushyant.